Neurosyphillis. So a lot of these patients can come in and they can present with stroke-like symptoms. But what you want to look for is the patient's history, for example, multiple sexual partners, or you look at their dermatological exam and it will show something like a diffuse maculopapular rash. Let's first talk about primary syphilis. You have chancres. These can easily go unnoticed. And then you have secondary syphilis, where you just want to check the patient's extremities and look for a symmetric maculopapular rash. This includes the palms and the soles. If you leave syphilis untreated, neurosyphilis can take over and it disseminates into the central nervous system. What happens here, which can take up to weeks or even months, is development of meningeal, ocular, otologic, or neurovascular manifestations, although many cases themselves are actually asymptomatic. If the syphilis becomes meningeovascular, which is considered the subacute event, or 2 weeks into dissemination, you can have things like headache, nausea, vomiting, neck stiffness, which makes it look like meningitis, and dizziness. Now, sometimes it can even show up as if the patient is having an ischemic stroke, such as sudden onset of unilateral weakness or hyperreflexia. On CT imaging, you might find focal segmental arterial narrowing of the middle cerebral artery, which is the most affected vasculature. The way we diagnose this is with CSF lumbar puncture. You would expect obviously a positive VDRL, mild protein elevation, and also lymphocytic pleocytosis. Lymphocytic pleocytosis just means that you have an elevated cell count of lymphocytes. The treatment for it is around 2 weeks of intravenous penicillin. The ocular manifestations include uveitis and optic neuritis. The otological problems include hearing loss or tinnitus, but these are all the early signs. The late signs include general paresis, progressive dementia, tabes dorsalis, and also sensory ataxia or lancinating pains, which is characterized by piercing or stabbing sensations inside the patient due to nerve irritation. So you want to differentiate the rashes between meningiococcemia and also neurosyphilis. For people with meningiococcemia, you want to look for a petechial rash, not a maculopapular rash, and also these patients also look very, very sick. They have a high fever, they decompensate very quickly. Lastly, the syphilis will not grow in the blood or CSF cultures. Petechial rashes are very pinpoint. They're round spots that appear on the skin as a result of bleeding. Maculopapular rashes are usually flat. They cover a larger area of the skin and they can be covered in bumps.